Hello, and welcome to today's webinar, National and State Behavioral Health Systems, Changes on the Horizon. My name is Deb Adler, and I'll be serving as the moderator for today's exciting discussion featuring Mark Covall and Sean Schreiber. Mark Covall is the current president and CEO at the National Association for Behavioral Health Care, NABH, where he oversees policy and management of the association, which represents more than 1,000 behavioral facilities, including psychiatric hospitals, general hospital psychiatric units, and residential treatment facilities and outpatient programs. Based out of the D.C. metro area, Mr. Covall brings over 30 years of experience of working with healthcare providers with the primary goal of removing barriers to care and expanding the behavioral health workforce. Sean Schreiber is the current Senior Vice President of Provider Network and Evaluation for Alliance Health, a regional health plan in North Carolina, where he has helped implement numerous community programs, as well as developed and implemented new services to address the needs of individuals with complex and chronic conditions. He previously served as a Chief Clinical Officer, where he provided leadership and oversight to all clinical programs within Alliance Health, including utilization management, multiple care coordination programs, and community relations. He previously worked as the Director of Development for Behavioral Health Providers, where he implemented new programs and strategic partnerships, and he also served as a consultant to behavioral health care companies, including Optum's Network Strategy Division. My name is Deb Adler, and to give you a little bit about me, I'm currently a Senior Associate for Open Minds. Prior to that, I spent more than 20 years in executive healthcare roles, serving in a variety of capacities, as Network Executive, Quality Management Executive, and Chief Operating Officer. I was the former Senior Vice President of Network Strategy for Optum, where I was responsible for the Behavioral Health Network Strategy, Contracting, and Development for over 185,000 providers, and have been very much engaged in programs to expand access and use alternative payment arrangements, particularly transforming from fee-for-service to more value-based arrangements. Today's webinar is sponsored by Otsuka America Pharmaceutical, Inc., Otsuka Pharmaceutical Development and Commercialization, Inc., and Lundbeck, LLC, committed supporters of the mental health treatment community. But first, I want to highlight where some of this content is coming from, and I'm delighted to share with you, if you haven't previously accessed our trends guide, that it's a free guide that's available to you. You can download it today. It was published in 2017 through Otsuka Market Access Trends Report, and it is really a compilation of a survey of over 1,000 payer organizations and helps bring to the forefront their future plans regarding how they respond to national and legislative and industry trends. So you'll see the link on today's screen, and you're welcome to download that free. I'm even more excited to share that in the coming weeks, we will have the second edition to the guide, and in that guide, we surveyed 1,265 payers, and we were able to glean what they were doing in response to national and state trends, what were their new innovations, what have they implemented, what's on the roadmap to be implemented. So it's a wealth of information, and much of the content on today's forum will be published in that guide. The guide was also supported through an advisory board from several large national payers, including Optum, Aetna, and Cigna, and contains 4 domains: national trends, state trends, population management innovation, and access and delivery systems. So let's dive into the content today. I would say that the programs that are impacted by policy change are pretty broad in scope. In fact, it might be easier to describe what isn't impacted. You'll be hearing today about legislation that impacts consumer access, as well as new funding, like the Cures Act, and how that's been a support to tackling the opioid crisis as an example. And you'll also hear about continued focus and expansion on alternative payment models within state Medicaid programs. So I look forward to launching in, and you'll be hearing from myself and my guest speakers on these national and state trends. So let's start with national legislation. There are 6 pieces of federal policy and legislation that I think are particularly pertinent to payers and providers in the behavioral health space. They are the Patient Protection and Accountability Act, CMS Final Rules for Medicaid Managed Care Plans, the 21st Century Cures Act, Mental Health Parity and Addiction Equity Act, Medicare Coordination of Care Codes, and Alternative Payment Arrangements. I'll be providing you with a quick overview of each, or my guests will, and we'll also provide some color commentary on how each of these pieces of legislation impact payers and providers. So let's talk about the first 2 of those 6 policy and legislation to get started. Starting with the CMS Final Rules. And again, this is featured in the 2019 Trends Guide. One of the things that I think is significant about the CMS Final Rules and the changes to the institutional mental disease IMD program is it allows populations once generally excluded from psychiatric inpatient care in freestanding hospitals to have access. So that's, certainly could have an impact on access to care, shortage of beds, as some of those previously excluded populations now have access to in freestanding hospitals. The other thing it changes is network adequacy. States will have the ability to set network adequacy standards and are not limited to and may exclude traditional travel time and distance requirements. So some changes there. And I think the other significant change, and we'll talk more about payment reform in a little bit, as well as the use of alternative payment models, but states are now using their authority to require Medicaid managed care plans to enter into, I would say, identifying quotas or formal percentage of health care payments that must be tied to value. For example, CMS has set a goal to tie at least 50% of Medicare payments to cost and quality by 2028, had set a goal of 50% of Medicare payments tied to cost and quality by 2018. Some of our own reviews and studies have shown that across payers, only about 30% have now entered into reimbursement arrangements that are tied to cost and quality. So there's ways to go. On the PPACA, Patient Protection and Accountability Act, I would say a number of notable comments. We do know that the rate of uninsured in non-expansion states is almost double that of expansion states. In fact, the use of managed care within Medicaid programs has reached 76%. The other thing that we're seeing an impact on the uninsured rate. Currently, the uninsured rate is at 9%. And if you've been following the changes in PPACA, you would know that in 2019, the tax penalty for not having insurance coverage ended. So this has been an area that there's been certainly a lot of focus on as the legislation continues to evolve. I thought I'd ask my guests a question, since both of them have experience with both PPACA and the CMS Final Rule. Are there other impacts that relate to either PPACA or the CMS Final Rule for Medicaid Managed Care that Sean or Mark might like to highlight?
Yeah, hi, Deb. This is Sean. I'd say there's, 2 things to highlight. Obviously, the CMS Final Rules, when we start thinking about new adequate network adequacy standards, I think from a payer perspective, making sure we have appropriate, understand our state perspective and have better ways to measure pure adequacy. It's not just enough in our mind anymore to have geographical access, but to make sure that patients aren't waiting too long for services. They can be seen timely for a follow-up after inpatient stays and such. So I think access continues to be a big thing on payers' minds as a result of final rules. And thinking about the Affordable Care Act, one of the impacts you hear a lot about is for hospitals. So hospitals, especially safety net hospitals, receive disproportionate share hospital payments, which basically cover some of the cost of taking care of the uninsured or individuals with Medicaid. Over time, those payments are supposed to be decreased and go away under the ACA. There's been several delays. A round of actual reductions is scheduled for this coming October. And again, there's been a lot of pushback. So I think concern about those safety net payments, especially in non-expansion states, is one of the residual impacts of the ACA.
This is Mark, and one of the things I would just add is with respect to Medicaid expansion, one of the biggest increases in access to care through that Medicaid expansion has been with SUD, substance use disorders. So the Medicaid expansion has had a significant impact on expanding coverage and access to both mental health, but even more specifically SUD. So it's a significant positive from that standpoint.
That's a great point, Mark, because actually SUD, substance use disorder, the next piece of legislation that I'm going to ask Sean to highlight is the 21st Century Cures Act. I think that has had a significant impact on access and funding for substance use disorders. So, Sean, if you would tell us a little bit about the 21st Century Cures Act and the Mental Health Parity and Equity Act, that would be great.
Right. So I think probably one of the most popular, well-known provisions of the 20th Century Cure Act is the fact that through what was called the State Targeted Response to the Opioid Crisis grants, about $1 billion over a 2-year period became available to states to implement a number of strategies to help address the opioid issue. Common things were adding things like getting more naloxone and rescue medications into the community, but a really big focus was also on expanding access to evidence-based substance abuse treatment, primarily medication-assisted treatment. So I think that's been one of the real big positive impacts of 21st Century Cures Act. HHS has recently reported they're releasing another $487 million to states to continue those efforts. So, also under the 21st Century Cure Act, there was a push to accelerate new devices and medications, not just for opioids, but across the board. And then there were a number of other kind of extensions of previously funded federal initiatives, such as jail diversion programs, funding for suicide prevention lifeline, and some more research and promotion of assisted outpatient treatment, which is, in essence, having people under some kind of commitment order to help engage them in treatment. I think another big driver of access has really been the Mental Health Parity and Addictions Equity Act. And obviously the access components of that were built upon by the ACA. But in short, the Health Parity Act requires private plans to provide parity for mental health and substance use disorder benefits. So if you don't have prior authorization requirements on certain physical health services, you're also not allowed to have those on behavioral health. It also makes sure there's parity, or took away actually some of the lifetime limits that were on behavioral health services. I think one of the key findings that's been seen as a result of the Parity Act is the out-of-pocket costs for individuals for their behavioral health services had decreased. So prior to the act, about 21% of individuals' physical health costs will come out of out-of-pocket expenses for commercial plans. At the same time, about 36% of the cost was bared out of pocket by the consumer. So again, I think between the Parity Act, the opioid crisis money available through the 21st Century Cures Act, better screening for depression, anxiety, and primary care, all these things are creating a really big push to increase access to behavioral health services, and really is forcing payers and provider organizations to think about how to engage a larger population now that there's funding available. The other thing we've seen since the Mental Health Parity and Addiction Act is pretty significant increases in utilization of behavioral health and substance use treatment disorder services, and significant spending along those ways. It should be noted that while the initial act applied more to these private groups, CMS enacted rules, I think around 2013, to make sure there was parity in both TRICARE products and in the Medicaid programs. So, as I was saying before, because access is becoming such an important issue for states and for provider organizations, one of the things that's been a challenge is the availability of psychiatric services and workforce. So back in 2017, CMS implemented some new codes that really allowed primary care practices to get reimbursed for providing a more integrated care experience for their members. These codes were extended to FQHCs in the following year. And some of the core is really to make sure that a primary care setting is doing better screening for behavioral health disorders by using some standardized tools. Typically hear things such as the PHQ-9 or the GAD-7, that there's care managers or social workers who basically work with a population of individuals who are deemed kind of more at risk or who have screened positive for some kind of behavioral health issue. And they're supported by a psychiatric consultant who provides consultation and staffing up to these social workers to better treat the members. And in turn, these social workers work with doctors in more of a care team model to improve holistic care for behavioral health issues. I think what's so important about the use of these codes is not just it allows for better integration of behavioral health care into a primary care setting, but it really greatly expands the capacity for psychiatrists. So you read nationally that there's a shortage of psychiatrists, a shortage of child psychiatrists. There tends to be more psychiatrists leaving the field than graduating and going into psychiatric residency programs. So in these collaborative care models, one psychiatrist using 3 hours of time a week roughly can support anywhere from 50 to 150 individuals receiving collaborative care. So again, another important way to start addressing access to behavioral health care. And 11 states have currently added these codes to their Medicaid program. Deb, another big driver of change in the behavioral health space, and really the whole healthcare space, as you mentioned, was CMS's kind of goal to get about 50% of Medicare payments that are tied to cost and quality. So CMS launched something called the Healthcare Payment Learning Action Network. And the goal of the Learning Action Network was really to kind of study broadly what's going on in alternative payment and develop a unified framework for us to begin discussing different payment arrangements. What they found in a 2017 study is that about a third of payments are really tied to both cost and quality metrics.